Great. Well, welcome everyone to our Fireside chat, supported by the Global Alliance for Genomics and Health. And we're delighted to have a guest today, Geoff Ginsburg. So Geoff is the Chief Medical and Scientific Officer of the All of Us Research Program at the National Institutes of Health in the US. He leads the Division of Medical and Scientific Research and is responsible for helping to set the scientific vision and strategy for the program. And we're going to have a chat here today. I'm going to ask Geoff a series of questions. He may ask me some things too, but we didn't make him do any work for this. So it'll probably be mostly me asking him questions. But we also welcome you all to submit your own questions. And you can, if there are questions that you want me to ask of Geoff or you want to be answered and addressed some way, please put it in the Q&A. Whereas if you have logistical questions or just want to make comments, you can put them in the chat, and I'll be monitoring the Q&A to make sure I ask those questions, but I won't be sifting through the chat if there's a lot of stuff in there. So with that, I'm going to open it up really for sort of an introductory question. This is really around a bit around your career, Geoff. So you've been in an academic university setting for a long time. And then you made the move to join the All of Us Research Program, which is sort of a move to the government side of the world. So I'm curious what inspired you to make that move, at that stage of your career not too long ago, and what it's like to have more congressional oversight of the work you do.
Thanks, Heidi. Also, thanks to the Global Alliance for Genomics and Health for extending the invitation for me to chat with you today, and also congratulations to you on your new role of a month old in the role as chair. The organization is incredibly lucky to have you. So I was in academia, and I just want to point out that I also went to industry. I went back to academia, so my career has been, I would say, distinctively nonlinear, and I'm pretty used to changing directions and environments. And actually, I think I thrive a little bit on bringing the learnings from one environment to the next and hopefully making the better of it. And first, let me say that academia is great. Lots of freedom, many directions that you can take in your research. And maybe you can relate to this, is that the trade-off is that there are also many agendas. And by its nature, academic organizations don't necessarily have a singular mission. And I was, for most of my career, been in pursuit of precision medicine. And actually, the company I was at was Millennium Pharmaceuticals, a former neighbor of yours in Cambridge. And the goal there was to create personalized medicines. And when I was there, I found it really inspiring and exciting to think about the prospects of personalized and precision medicine. But the company was kind of arm's length from the patients. That's why I went back to academia, and I joined Duke to see if I could do something around transforming healthcare and making a precision medicine health system. And we made some progress, but as you know very well, in your role as the chief genomics officer, it's some of these institutions don't necessarily have the buy-in and really understand the financial aspects of or the financial rationale for a precision medicine health system. But anyway, so I saw the All of Us research program as an amazing platform to set a national agenda for precision medicine. And while I'm not completely sure how we're going to get to the goal line of making precision medicine, I really think joining the government at this point in my life was a real opportunity to shape a national agenda for precision medicine. It is a once in a lifetime opportunity, at least for me, and that's what really motivated me to make the leap from academia to government. But and you asked about Congress, and I actually don't think about Congress a lot. But I do think about something that I really didn't focus on in my prior roles, is really being there for the American people and serving them and trying to make their lives better. And if the All of Us research program can embrace the diversity of this country, as we might talk about, and deliver value to participants in the public, I think then Congress will be very happy. So anyway, I hope that wasn't too long an answer to your question, but I wanted to give you a sense of my sort of nonlinear journey and not being afraid to move across great, different, very different environments for my career. So
That's
thanks for asking me that.
that's great. Thanks for sharing that. I'm going to also ask a broad question because I'm not sure everyone in the audience knows exactly what the All of Us research program is. So I wonder if you could just, briefly talk about what is the aim of the All of Us research program. You've alluded a little bit in your, comments about your own career path, but if you could talk about the goal of that project and really where it is in its current progress.
Yeah, thanks. So first of all, if you, I want to point out, oops, wrong finger, point out the website joinallofus.org. So I would encourage you to look at that website and maybe even join whoever's in the audience to think about becoming a participant if you haven't already. But I guess one way to think about the All of Us research program is a transformational platform to change the way we deliver precision medicine. And I think I almost have the mission statement for the program memorized. It's along the lines of accelerating health research and medical breakthroughs, enabling precision medicine, by which we mean individualized prevention and treatment and care for all of us. And it's purposeful in the mission statement to have all of us in lower cases because it really is meant to shine the light on the diversity of the U.S. population and the ability of this program to really make a difference in the lives of all Americans. And so that's the overarching mission statement for the program. But it started in 2000. Well, it started as a concept, I think, during the Obama administration as the Precision Medicine Initiative. And in one of the State of the Union addresses, it was announced. And not too long after that, it began to crystallize with Francis Collins at the helm of the NIH and many others. But the launch point was 2018 when the first participant was enrolled. And now we're 5 years and one pandemic, into it. And I'm really excited to say that we have nearly 760,000 people who have consented to the program. Over 500,000 have completed, what we call the basics, meaning giving a biological sample, answering a few surveys, donating their electronic health records, and providing some physical measurements. And true to the I think the very ambitious goals of the program. Even at this point, we're over 45% non-white in terms of self-reported race and ethnicity. And we have this category of what we call underrepresented in biomedical research, which are people that have been largely excluded from even being asked to be part of a medical research study. And there are many categories like that: people who live in very rural communities, people of low socioeconomic demographics, people who are extremes of age, even sexual gender minorities. There's about a half a dozen, I'm sorry, close to 10 different categories that make up what we call underrepresented biomedical research. And right now our cohort is about 80% in that category, which is phenomenal. And for those of you, I know Heidi, you know this, but those of you in the audience who may have been at our researcher workbench and are active users of our data, I'm very proud to say that last April we released 245,000 or more whole genome sequences, 312,000 genetic arrays, genotyping arrays, and a whole series of data types. Well, I guess I'll take a step back and say that at the core of the protocol, we embrace 5 major data streams. They're electronic health records, physical measurements, sample collection, which then gets converted to whole genomes and sequences and genotyping arrays, physical measurements, as well as wearable digital health technologies. So those 5 data sets are the core aspects of the program. And certainly, I mentioned some of the numbers, so you get a sense of the scale. So that's a metric, I think, of some progress and success in the program, to your question. The other thing I think I'll mention, which we're very proud of, is the number of people that are using our data. At last tally, over 8,500 workspaces now have been created by researchers, both in the United States, which is the way that we opened up the program to
Mhm.
not-for-profit institutions across the US. And then at the end of last year, we opened up to international organizations, and we're now have researchers on 6 continents
Mhm.
using our data. So that's a terrific milestone in my opinion. And of course, the hope is that all of those individuals will just do amazing things with the data and carry out breakthrough science, which is part of our mission.
That's great. And actually, I want to dive in a little bit deeper because it is no small feat to enroll and recruit such a diverse population. All of us who have tried to diversify our, research studies have recognized that it's not straightforward to, recruit. And so I wonder if you could comment a little bit about some of the strategies that all of us has done to really achieve such amazing diversity in this cohort. And as you said, not only of, racial, ancestral, ethnic, but also of many other metrics of diversity and underrepresentation. So can you comment a little bit about what the program has done to achieve that?
Yeah. Well, good question. And first of all, let me say, as the Chief Medical and Scientific Officer, I take absolutely no credit for the awesome work that my colleagues, particularly Holly Gariak, who's our Chief Cohort Development Officer, and Kareem Watson, who's our Chief Engagement Officer, have done to make that happen. So I guess thinking about your question, one is that we have sites all over the country. Um, I don't know the exact number off the top of my head, but it's close to 100 recruitment sites. We call them health provider organizations. Um, we have deliberately partnered with a number of community-based organizations that represent diverse groups in the community and minorities. And we also have a diversity of enrollment sites, of course, in their geographies.
Mhm.
One of the things that I think is an innovation in trying to achieve this diversity is the use of mobile enrollment vehicles. So we
Mhm.
have vans, several vans that go travel around the country all year round, or most of the year except for the winter, to really reach people where they are, particularly the people that don't have access or can't travel to
Mhm.
centralized healthcare facilities. We have a strong partnerships with federally qualified health centers, FQHCs, that really have been enabling for us to reach out to some of the diversity of populations that I mentioned. And we have, I think, something on the order of 45 participant ambassadors. And
Mhm.
these are people that just, have a passion for what we're trying to do, are our partners in what we're trying to do, and as the word ambassador really highlights, they're really oftentimes the main way that we can communicate with the community
Mhm.
and really excite people about why should they join? How are we going to bend some of the curves in healthcare and reduce some of the gaps in diversity and data?
Mhm.
I think we rely a lot on our participant ambassadors to really help us do that. And the other thing I think is important to mention is a core value of the All of Us Research Program is transparency. And I think at the heart of your question is being able to garner the trust of people who have largely not necessarily trusted researchers in general and the U.S. government specifically.
Mhm.
So a constant vigilance around communication and transparency, I think, is part of the ethos of the program.
Yeah, absolutely. We do have a question that's come in that's related to one of the questions I was going to ask you, so I'm going to just ask it now. So the question was, could you tell how you are storing, maintaining, and disseminating such a huge amount of data? So maybe you mentioned the researcher workbench, but maybe describe a little bit about actually how this data is put out there, how to get access, like what's the platform, a little bit about the workbench and so on.
Yeah. Again, a lot of this was accomplished before my time, so I really don't want to take credit, but a lot of people, including people at your institution, Heidi, the Broad Institute, as well as Verily and Vanderbilt. Together, they form our Data and Research Center, or what we call the DRC, which is probably not meaningful to people on in this chat. But so the idea was to build an accessible and secure platform. So as I mentioned, we have 5 main data streams, uh, all emanating from the donation of data from participants, and they stream all of these data get contributed to the platform at the Data and Research Center, which has several components. One component is the raw data repository, so the data all flows into an RDR. The DRC undergoes a number of quality metrics and curation processes for the different types of data, very different for each type. And eventually, over a period of, let's say, 6 to 8 to 12 months, the data moves into the curated data repository, which is the data store that is accessible to researchers. So any of you, assuming your institution has a data use and research agreement, or DURA, can go to the workbench, which is researchallofus.org, all one, researchallofus.org, register, create an account, and begin to do research. It should be that easy. We have developed several what we call tiers of access, depending on the kind of data that you want to use, and just to make sure that we have very clearly articulated rules of the road, and make sure that our participants recognize the privacy and security that their data is living under. We ask researchers who are going to use the data to go through training modules to recognize that, and more training modules depending on how more sensitive the data is. So we have the registered tier, which has electronic health record data, which has obfuscated dates and a few other things that don't make it exactly it's not identifiable, but just to make sure that there's some ambiguity in the data, and it's anonymized and de-identified. Then the control tier contains more sensitive data, which is where the genomics data resides. So again, passing the training modules allows any of the researchers who want to use different data types that kind of access. Yeah, I think, as I said earlier, any institution in the United States should have a data use agreement. And we have I should say, if your institution doesn't have one, I would encourage you to ask your administrative folks to apply for one. We have over 600 organizations in the United States already that have these DURAs. And as I mentioned earlier as well, that we're extended access to international organizations. I don't know if anybody is here that is from outside the United States, but that process should be also well underway and up and running. So hopefully you can apply for that as well.
Yeah. And let's say there's an individual out there that either isn't at an institution that can apply or is willing to apply, and is there any path for an individual to get access to this data set?
That's a good question, and I don't think I know the answer to that question. Maybe you do, but we definitely have in our sites the notion that we want to encourage not just use of our data by more established scientific communities, but by citizen scientists. And the mechanism by which that will happen is still yet to be determined, and is probably relevant to your question. But it's one of the ways that we're thinking about that is to encourage people, the public who has questions, research questions that they want to have answered, to partner with scientists that have access to the workbench. And but I can say that also some high schools have DURAs, data use research agreements, and high school teachers are now using the All of Us data set in the classroom. And as a matter of fact, some high school students have have things like abstracts accepted to meetings based on work that they've done in the classroom with their teachers, which I think is phenomenal.
Yeah, that is awesome. So it actually brings me to, we've talked about enabling access to this rich data set, all the people are using it. And so, obviously, as a result of that, a lot of the research that will come out of the All of Us program is in some ways dictated by the community that uses the data set. That said, with you and your role as the chief scientific officer and helping set the scientific vision and strategy for the program, there's a balance of you and the other leadership of the All of Us research program thinking about that scientific vision, because you need to think about what samples are you going to collect and what kind of omics data will you generate that allows and enables some of those research projects to be done. So how do you think about your role as an individual, the CSO, and versus the external community's role in really, and then the leadership, Josh, Denny and others, in thinking about the scientific mission, vision, and goals of the program, and how do you go about like making those determinations?
Well, what your question sort of speaks to what my life has been like for the last 2 years since I joined the program, which I was really hired to set the scientific vision and priorities for the program.
Mhm.
And I completely respect the fact that researchers using our data can and should pursue whatever science they want. But if our program goals are to advance precision medicine, we really can't leave that to kind of the stochastic nature of what researchers may want to do. We have to create a strategy, at least, that helps us, kind of channel people in certain directions. And so I spent my first year as chief medical and scientific officer developing our strategy. I did a listening tour of many of our consortium members, the funded investigators that have received funding from the program. We have a science committee. We have an advisory panel. We have a lot of people that want to give us guidance and advice. So I really took full advantage of that, and they're really amazing people with lots of insight. And I also well, so we did come up with something that I'm happy to describe what that strategy looks like at a high level. And as well, I think to your question is once having a scientific strategy, is I'm sure you have for your lab or for your organization, we can use that to make decisions about what priorities we want to have. Like
Mhm.
the researcher community, the 8,000 plus, 8,500 plus people I mentioned are going at it, which I'm excited about seeing what the investigator community is doing. But I can also influence direction by saying, putting out funding announcements and partnering with other NIH institutes and centers to be very much more specific and deliberate about directions that we want to see people go, because that's where the money's going to,
Yeah.
that's where the funding will be. So that's one way, a way that we have implementing the scientific strategy is to channel our priorities into funding announcements. But it doesn't stop there, because over the next year or two, we'll begin to establish other kinds of partnerships with outside of NIH, with commercial firms and other organizations that will be much the nature of those partnerships will be very aligned with the scientific programs that we want to see happen. Again, it's all in the service of precision medicine.
Mhm.
And my team is watching very closely what the research community is doing with the data, because we know that we didn't think of everything. We couldn't.
Yeah.
And there's probably a lot of really exciting work that's happening that we just never crossed our minds. So the scientific strategy is effectively it's a living thing. It's an evolving strategy, and it's meant to morph over time
Mhm.
in response to how science is changing and in response to what we're hearing from the investigator community. But fundamentally, we're still keep our eyes on
Mhm.
that prize of precision medicine.
Yeah. That's great. Another question, you know, as we've talked about any scientist can come in that has access to data and ask questions of it. But there is the question of how do you, as an organization that generates this data, ensure its responsible use? And as someone who's both a PI within the All of Us research program and having gone through all the training, because I also use the data, there was a lot of training around this issue. And I wonder if you could talk a little bit about how the program tries to highlight, what could be sensitive areas of research and ensuring responsible use of that data and thinking about downstream impact of the participants based on certain studies that might be done that might stigmatize and other things. So can you talk about some of this balance in terms of really wanting to put out the data and allow anyone to ask any scientific question they want versus where are sensitive areas and how do you try to steer and ensure that the patient's samples are treated with respect and the findings that come from this study, recognize sometimes some certain sensitivities of those data?
Yeah, it's a big question. Before I answer it, you gave me permission to maybe ask you a question. And you said this. You said you've gone through the trainings, and I wonder if you could just share a little bit with the audience of what that was like. Just so they have a sense of what you're talking about, if you don't mind.
Yeah, it's been a little while since I took it, but I do remember, most of as someone in the academic medical center world, like we all do a lot of these online training things. Most of them are around active shooter and, you know, like diversity, and there's just, and infection, fire safety. There's all of the things that we do, right? And so, I needed to go through this training, and I was assuming that there would be, security of the data and logistical things and important things. And I was actually hadn't recognized it until I was in there just how much really thoughtful effort went into talking about stigmatization, the risk for stigmatization from the kinds of studies that might be done with this data, and really trying to share the diverse set of perspectives of the participants whose samples have been gathered, and giving examples of types of sensitive research and how different individuals might view those kinds of studies, and just really trying to educate around these topics. And so it was, it took a while to go through this training, but it was the first time I'd actually ever had that type of training in such a sort of systematic and deep way. So I congratulate those who developed those modules, but it is something that you really have to give some thought to, and that not every person always thinks about the downstream ramifications of the questions they ask and the research that they do, right?
Really appreciate your taking the time to answer that question because I just wanted it's important for others from people to hear from people outside the program in a sense of what it's
Mhm.
like. So thank you for that because as I thought about your question, the word of incredibly thoughtful process, comes to mind that uh, this was all pretty new to me when I joined the program, to be honest with you. Like it sounds like it was almost a little new to you because you hadn't had that kind of training. And a lot of people, probably smarter than me, thought about ways to provide a secure data environment accessible to now nearly 9,000 researchers and still assure and protect the privacy and other aspects of our participants that need to be protected for them to feel comfortable being a participant, continuing to donate their data, and to continue to trust us as an organization. So, a few things are worth mentioning is that I mentioned a core value of the program is the transparency that we have with our participant community, and we are continuing to foster ongoing communications about how participants' data is being used. We really make an effort to communicate back to participants about their findings that are coming out of the data that So they see like, oh, if without my data, this may not have ever happened. So we have a participant-facing newsletter, and as papers are published, we try to really emphasize the importance of what their data meant to those researchers to be able to carry out that research. So there's this, I hope, circle of confidence that the data is being used in very important and productive ways. Um, we also have policies in place that assure the data security and privacy. I'm not familiar with all the details, but there's definitely access controls and encryption, and there's also regular security audits. There are, I guess, software that is watching very carefully, not in a Big Brother type of way, but just to make sure that people aren't doing things in a nefarious way, or, downloading data is not something that we do. Our data is hosted in a cloud environment, so we're watching closely for that type of thing. Of course, at the front end of this is also an important informed consent process that we tell people as explicitly as possible in terms that they will understand about, what the program is all about and how their data will be used. Uh, we um, we have a research access board. We have several governing bodies within the program that do reviews of workspaces. So when you register at our workbench, you're asked to provide some sense of what your research will be about. There's a title, an abstract, an intended use, series of questions that people get asked to provide, and we're very deliberate in reviewing those workspaces so that uh, and there are when people deviate from some of our principles, we do a very rigorous review, and I have to say that some workspaces have been closed down because people have done things that we just didn't think were going in the right direction. And the last thing I'll say, maybe, or we can continue to talk about this, is that in order to ensure that we preserve privacy protection, we're very clear that researchers are not able uh, to have counts less than 20 in published data. Now, I know that may fly in the face of rare disease research, which by its nature are going to have small counts, and we're working through that. But I do think that's been very useful to ensure, participants that have very unusual characteristics that they're not able to be identified through the research that's being done on the data set.
Yes, yes, it's definitely a challenge because as you said, in the rare disease space, most of the variants that mean something are N of ones, so it's a challenge.
Well,
But
I should say that we have a mechanism by which researchers can apply for what's called an exception.
Mhm.
So if you're doing something that, the work you want to publish will necessitate having counts less than 20 as a result, there's a process by which that can be approved, and it has been approved. So it's not like it's completely off the table, but there's a process.
Yeah, and I will say we did get an exception to put the counts from the genomic data in terms of the variant counts that are on the public browser. So you can open up the public browser and see that there is one person in all of us with X variant. So
Hmm.
now you get on the public browser, obviously you don't have access to the phenotype, but at least you that the awareness that that exists is out there. So yes. I did want to ask a little bit about longitudinal, engagement. So one of the values of this cohort is the ability to engage over time, and to have health records that are continually flowing in, that connectivity to the individual's healthcare data. Um, but and you've mentioned some of the ways to keep that engagement going through newsletters and awareness of what's coming of that research as ways to keep engaged. At the same time, one of the things that I've noticed, yeah, is that especially when you're trying to enroll an incredibly diverse group of individuals, geographically, socioeconomically, that relying entirely on electronic modes of communication in terms of engagement, which is a necessity, at the scale of a million people cohort. So, like, how do you balance really trying to have that diverse cohort not only enroll but stay engaged, yet some of the challenges of that long-term engagement when you're relying on electronic and that an email continues to work and all of those things?
Yeah. A couple of things that come to mind. One is I just want to reflect a little bit on things I've already said, is that our participants are partners. So
Mhm.
we want to hear from them as often as possible when things are going well and when things aren't going so well, so we can continually. I like to think about this our platform as a learning
Mhm.
platform. It's continually optimizing, particularly with the feedback loops that I'm alluding to. And you mentioned electronics. I'll just say that I'm very sensitive to the digital divide, as I'm sure you are and many people here are. Believe it or not, we're probably going to do some retro stuff going forward and go back to paper in certain situations, because it's absolutely necessary to do so to make sure that we have the diversity. Our new we use a platform to communicate with participants. Our new partner in that is Nork from Chicago, and they have also diverse methods for reaching out to individuals as an organization that's been largely involved in survey data. Um, I think and I mentioned that we use things like mobile vehicles to get to communities, and of course the engagement partners, and to achieve the diversity. But the engagement piece on an ongoing basis means that we have to be in touch with people on a fairly regular basis. We don't want our participants to forget about us. So one of the things we've done, I think, very well from the beginning of the program is launch surveys, which is a fairly good way to keep in touch with our participants, but also to get relevant data. And we've had about 8 surveys, and I can't list them all, but they're on the researchallofus.org website. But some of the ones that I think are of great interest to the researcher community that we've also launched within the last couple of years is the social determinants of health survey. So really trying to get insights into the environments in which people are living and what's affecting their lives on a daily basis that may not be in a clinical record. For sure, it's not in a clinical record. So we have a very extensive social determinants of health survey. In 2023, we launched a mental health and well-being survey, which is very timely, particularly on the heels of the pandemic, to really take a deeper dive into understanding both the way that people's behaviors have been impacted by various aspects of their lives, as well as their personality types. And just to give you a sense of in 2023 July, we launched the mental health and well-being survey, and over 100,000 people have provided data as of earlier this year. So that's a pretty strong testament to the commitment of our participants to continue to be engaged. And we have effectively a pipeline of surveys that'll come out in 25 and 26 and 27, et cetera, all being driven by the scientific strategy that I mentioned earlier. But a very unique aspect of our program that I imagine several of you are aware of is our commitment to return results to participants. And that's a really, really important commitment that we've made. And it's a really effective engagement strategy for sure. But more than that, it's the kinds of results we're returning will be at the core of precision medicine, realizing precision medicine. So in 2020, we began using the genomic data, returning ancestry and traits, and nearly 200,000 people have seen their ancestry data. And when I say traits, it's kind of non really health related stuff, but like your preferences for cilantro, what kind of earwax do you have? Are you lactose intolerant? Half a dozen or so traits are things that we've provided to our participants. But in December of 2022, we launched our first health-related return of results, which I think hopefully is of great interest to this audience. We have the ACMG 59, which is not the current ACMG list, but it was the one that we started with. So we're returning results on likely pathogenic variants in that. And Heidi, your team is incredibly tuned into and helping us do that. So thank you for that, as well as genetic variants in 7 pharmacogenetic genes, pharmacogenes that are involved in metabolism of many of the drugs that are across the United States. And just to give you some data, around 3% of our participants have a reportable actionable variant in the ACMG list, and almost greater than 95% of our participants have a potentially actionable gene in the pharmacogenetic variant. So this is important health-related information, and the responses that we've had from people that have received their results has been uniformly positive in how impactful that has been. So that's continuing. We're still going through effectively a backlog of return of results data from our participants. But again, thanks to Heidi and her team and others around the country, we are able to deliver about 5,000 results each week, and that's ongoing. So those are things that are really been helpful in sustaining and incentivizing people to continue to participate in the program. But I should mention 2 other things, if it's okay with you. One is we're recognizing that we may need to provide some incentives, just monetary and incentives, which we have done, and we'll continue to do that. Certainly, a lot of our participants are altruistic, and I don't think the financial incentives are terribly important to them. And in 2025, we will start our first reassessment and re-engagement opportunity, by which I mean we're going to start bringing people back. And from the 2018 time forward, we'll learn more about what happened to them in that interval. We'll do some comparative analyses between their baseline data and the data that we collect at that reassessment time point. We'll collect additional biological specimens. We'll return results, and we'll probably do some other things that will enhance our data set, like certain types of imaging, or give them some wearable devices to use, and use that really unique time to bring people back as a time to really expand the data set that we're collecting in service of the science and precision medicine.
Yes, excellent. Completely agree with those things. And actually, we did get a question in. And it speaks to the area I was about to head into, which was your role in the IHCC and thinking about other cohorts around the world. And we have a couple questions here around all of us has developed an amazing infrastructure. You have mechanisms for sharing learnings and experiences with other national efforts. And then Peter asked, how does AOU collaborate with other similar initiatives internationally and globally? So all sort of centering around some more international engagement and how the All of Us program has done that. And I'm guessing some of your role in the IHCC might relate to that as well. You could speak to those things.
Thank you. And hi, Peter. Good to see you in print. IHCC, just for those of you that don't know what IHCC stands for, it's the International Health Cohorts Consortium, formerly known as the International 100K Plus Cohorts Consortium, which was established in 2018 to really assemble cohorts around the world to create a platform that would accelerate science beyond what any one cohort, even as wonderful as all of us, could do, because IHCC currently represents about 60 million participants, which is a phenomenal number even compared to the 1 million that we aspire to have. And we recognize, of course, that across the United States, there are some very important cohorts, starting maybe with the early Framingham study, in 1948, but now, with million veterans program. So we're in really constant communication, or I shouldn't say constant, but frequent communication with other cohort leaders around the country, as well as globally through the IHCC, to enhance our ability to both combine data sets in ways that will make analyses across cohorts, much more facile, and and to also harmonize our data if possible. I mean, we um, we post all of our surveys and a lot of our methodology on our public-facing website with a very explicit intent of having other groups that are starting or have existing longitudinal population studies to use our data and methods so that we can do crosstalk between them and not have to do some transformation to harmonize the data, which often is the case if it can be done. So I urge any of you that are involved in your own cohorts of population studies to use our data, use our surveys in particular. And the other, it's worth mentioning, I didn't do this earlier, is that the electronic health record data right now across the program is streaming in from about 25 different vendors across the United States of the over 150 or 200 that there are. And people like Josh Denny and others that know a lot about this space more than I do, insisted on the OMOP data standard being adopted as the standard for our electronic health record data. So the transformation using OMOP occurs actually locally at the sites that are shipping us or sending us their electronic health record data. So when it arrives in the Data and Research Center, it's already has standardized elements, which has been, I think, a real solution, an important solution for how we have been able to achieve the kinds of accessible data and harmonized data that we have. To the first question, the question on in the Q&A, I'm not sure that we've optimized the way that we share our learnings, but certainly we've published a lot of papers on things that have gone well and maybe things that have not gone so well in the literature. Before we had scientific data, a lot of the publications coming out of the program were really focused on what it took to build the infrastructure and some of the key lessons learned. And if you haven't been to our website, there's an amazing amount of information on our resources page that are really there for researchers to basically understand, what we've done and how we've existed and what we're going to do in the future, but also to encourage, as I said before, researchers that are thinking about this for the first time to borrow as much as our ideas as possible. And on the international front, and I should acknowledge Peter Goodhand and I, along with Michelle Ramsey, are the co-chairs for the IHCC. So Peter, you probably know the answer to the question you asked based on your role in the IHCC, but it's not a slam dunk that you can bring cohorts from around the world together and have them play nicely with each other and harmonize data. But we were able to, even around the pandemic and shortly afterwards, instigate through funding opportunities that the IHCC provided, get cohorts both from well-resourced countries as low as limited cohorts from low middle income countries or limited resource settings to really buy in and share their data. One thing that the IHCC is doing actively, has been doing actively over the last several years, is acquiring the data dictionaries from the cohorts around the world. And I think the numbers are up to close to 50 data dictionaries have been harmonized to create an atlas that is on the IHCC website. The point being is that one is that it allows for harmonization of some of the metadata that exists within those cohorts, but allows individuals around the world to go to the atlas and essentially query and potentially build a virtual cohort and then contact the relevant cohort leaders to try to assemble the data that will allow them to do research that would otherwise not be possible, maybe at all, particularly if they're not part of a cohort. So I hope I know I've talked about a lot of things, but I hope I gave a sense as that we're in this really interesting time to facilitate and encourage international efforts like ours to come together and do something that will impact not just precision health in the United States, but global health, if that's possible.
Yeah, and I do also want to point out just around the question of engagement internationally. So the All of Us Research Program is both a driver project of the Global Alliance and participates in the National Initiatives Forum, where there's active efforts to share experiences and David Glazer, myself, and others from that work within the All of Us program have been part of sharing both on the technical side, from David's end, and on the return results side from my perspective. And there's other members, and Angie Music spoke at our last meeting that we had at Global Alliance. So there's definitely, as you point out, desire and opportunities for engagement that the All of Us program has been part of. I did want to you speak to, like, a huge focus of the Global Alliance is around federated approaches to data sharing and to science, in part because of a necessity. Often these large data sets can't be physically combined. As you alluded to before, the All of Us data set is sitting on a cloud-based platform, the researcher workbench, and can't be downloaded. That is now also true of the UK Biobank data set. So, and I'm aware of, some work recently from Alex Spick, trying to show, and define whether you can do the same science through federated analyses as you can if you bring the physical data. So I don't know if you want to comment at all a little bit on, you know, those endeavors to use the All of Us data set with others to actually do new, discover new things, or prove that they can be done through federated approaches.
I'm definitely willing to comment, but I noticed that David Glazer is in the chat, so he's certainly one of the people I would go to for some of these for some of the technical aspects. But I didn't know the term trusted research environment until I met David and Chris Lunt, our chief technology officer. So they've taught me, that's, well, actually, I think we do have a TRE. That is what our data set is. But then the question is, how do we bring a TRE from All of Us together with a TRE, let's say from the UK Biobank? And I think that paper that I guess is in the chat that you alluded to, at least demonstrated the fact that pooled analyses may not be 100% the same as meta-analyses, that the things can get lost, particularly in the meta-analyses. It seemed like the pooled analysis opportunity was a richer opportunity, particularly for rare genetic things that depended on rare genetic variants and counts in the data. So I can tell you that with David and Verily and Chris and Rory Collins and their team, we've been really talking about how to create structures that will allow for data not necessarily to be downloaded, but to coexist in a place where researchers can answer a focused question, finish the work, and maybe that environment goes away, and the data is not, the data goes essentially returns to where it was originally. I think there are creative solutions to this, and I do see a future where TREs that are set up between cohorts that allow for these federated analysis is going to be the future of the way we will do research. Otherwise, we'll still end up with a bunch of silos, which nobody really wants. Which and that's the goal, is to try to create that liquidity and fluidity of data. So I hope it did that some justice. I know people like you, Heidi, and others in the audience will probably have more insights as to the technical aspects of how to do that. But I think that's the way to go.
Yeah, and David Glazer had put into the chat to the panelists the paper that I was referencing, but I pushed it over to the full chat, so everyone in the audience should have that particular paper now. And there was a comment from Don Newsham. Your note now: federated data sets is so timely. ISO TC 215 just published a standard that strongly supports federated genomic data set sharing. Genomics informatics requirements for interoperable systems for genomic surveillance. So progress being made in space, and certainly a recognition that this is an area that we will all need to embrace and come up with creative solutions like TREs, trusted research environments, to spin up those analyses if you need to do them physically together, but also methodologies to do them, send your analyses out as our Global Alliance robot in our video has done. So I think we'll all be, making progress in that space to come. But we are down to the last few minutes, and so I do want to just let you have the last word. If there's anything that last message that you want to share, whether it's what you're excited about in the future of the All of Us research program, or words of warning, or whatever message that you'd like to leave with, I wanted to give you the last couple minutes to close us out.
Thanks, Heidi. I am really excited just about the trend in the papers that we're seeing coming out of the program, where I guess the proverbial hockey stick shape of the curve, where we crossed 300 publications at the end of 2023. We're thinking that by the end of 2024, we'll have over 500 papers. A lot of the best is yet to come, but we've seen rich use of genomic data already. Really taking deep dives into things as fundamental as, how does type 2 diabetes manifest across different race and ethnicity groups? What's the impact of social determinants of health on diabetes risk and genetic variants, that type of thing. We've seen, people building predictive models for glaucoma. We had a great observation in, I think, one of the Nature journals that showed maybe something that you all believe in, that step counts using Fitbit data actually reduces the incidence of chronic disease across 20 major disease categories or more that affect the health of Americans. We saw a paper recently showing that there are protective variants in the APOL1 gene in African Americans that harbor a mutation that can lead to chronic kidney disease and dialysis, which means that there could be therapeutics against people that carry that gene that will, ensure that they don't. So I'm just excited about what the data has already been able to deliver in a short period of time. And I strongly encourage the research community, it's represented by GA4GH and others that are here, to just go at it and do your best to create innovative science.
That's a great note to end on. And I would just like to say thank you very much for taking an hour out of your day to spend with all of us, literally all of us here and all of us there. So thank you very much for your time. And I hope the audience, that we didn't quite get to one last question, but if the anonymous attendee wants to email that question to me, I will answer it. It's about how we return results. But I want to be respectful of everyone's time and end on time. So with that, I just want to thank you, Geoff, thank the audience, and see you again soon enough.
Thank you, Heidi. Thanks, GA4GH.
Yes, thank you. Take care, everyone.